Welcome everyone to today's webinar, Advances in myositis-associated lung disease treatment. I'm Kelly Mills, and I'm filling in today for Sharon Lee, our Executive Director, as the moderator for today's session. Please feel free to add any questions as we go along to the Q&A heading at the bottom of your screen, and I'll read them out to Dr. Shapera. There should be time at the end of the talk for more questions as well. We are very fortunate to have Dr. Shane Shapera as our expert presenter today. He has the great gift of making complex topics like myositis, or hard to pronounce things, associated ILD, understandable for those without medical training like you and I. A little bit about his background. Dr. Shapera obtained his Doctor of Medicine in 2003 from the University of Toronto and completed his internal medicine and respiratory residencies in Toronto as well. He then added a clinical fellowship with an emphasis in interstitial lung diseases. He was appointed to the Faculty of Medicine at U of T as an assistant professor and clinical educator in December 2011. He's been an innovator in his role as an educator, and you'll see why, and has received numerous teaching awards since his appointment. He is currently the director of the Interstitial Lung Diseases Program at the Toronto General Hospital, UHN, and is an associate professor in the Faculty of Medicine and Division of Respirology at the University of Toronto. He also works with the Toronto Lung Transplant Program, providing pre-lung transplant assessments for patients with ILDs. Dr. Shapera is the author, co-author, and contributor of more than 60 medical publications. He's also a valued member of CPFF's Medical Advisory Board and a favorite presenter of our patient-focused webinars. So over to you now, Dr. Shapera.
Oh, thanks, Kelly.
Sorry.
You're genuinely making me blush, but thank you so much. It is always my pleasure to get to present at Pulmonary Fibrosis Awareness Month. I think that this is really one of many fantastic things that the Canadian Pulmonary Fibrosis Foundation does. And so it's my pleasure. And you know, when Sharon Lee asked me to speak on what topic I wanted to talk this year, I sort of realized that this is what I've been traveling around Canada teaching about for doctors. And so I felt like this is where the money's at. This is an exciting field that is evolving quickly. And so it's a treat to share with you guys what I've been sharing with doctors all over the country. So here are my financial disclosures. I've worked with several companies that do research and treatments in pulmonary fibrosis. And here's sort of what I'm going to try and accomplish today. So I'm going to have four main objectives. I'm going to talk to you about the epidemiology, or what the numbers look like when we talk about this category. And I'm sorry for the language, but the official name is called the idiopathic inflammatory myositis. And I'm just going to shorten that for myositis going forward. And we're going to talk about myositis and the interstitial lung disease that comes with that condition. And I'll explain what myositis is, how its ILD presents, and how that's very similar to some of the other ILDs that we hear about more often, like rheumatoid arthritis lung disease and scleroderma lung disease. I'm then going to talk a bit about some of the immunomodulatory therapies that guide our treatments. So this means medicines that adjust the immune system to try and stop our bodies from attacking the lungs in this condition. We're then going to move on about anti-fibrotic drugs, or drugs that deal with the scar tissue formation in the ILD of myositis. And then finally, I'm going to share a treatment algorithm for the management of myositis. And whereas my treatment algorithm is really meant to be for the myositis-related ILD, those of you who might remember a few years ago, I gave a talk on scleroderma ILD. And the message is that these are very similar conditions. So a lot of what we've learned from myositis over the last couple of years can apply to other conditions that are rheumatologic as well. So before we begin, a few things. The first is there are very few prospective studies of treatments in myositis lung disease. What that means is there's not a lot of studies where we say, okay, we're going to give half the patients with myositis this and half of them a placebo, and we're going to see what happens. a lot of our data is extrapolated from other diseases like scleroderma, and a lot of it is retrospective, where we kind of look back at experiences that people have. So that's why I use these two great graphics. The one on the top is saying that we're going to check your hindsight. And so you have to remember, we have to be cautious whenever we're making assessments based on similar diseases, or when we're using retrospective data instead of data going forward. And the other part is that, you know, we're a little bit kind of like, we're hammers and everything looks like a nail. So in the interstitial lung disease world, this falls into the autoimmune lung disease category. And so we apply a lot of the principles that we use from diseases like scleroderma when treating myositis. So how do we make a diagnosis of myositis? And what I mean by that, as I'm going through my slides, is like, what the heck is myositis and why do you care about it? So myositis is in a category of called, the official name, as I said, is idiopathic inflammatory myositis. And what this is a group of autoimmune diseases. So it's your own immune system attacking itself, where you get inflammation in the muscles. If it's only the muscles, we call it polymyositis. Poly just meaning it's lots of, and myositis just meaning it's muscles. So polymyositis means inflammation in a bunch of muscles. But you can also get skin disease because there's lots of similarities in the structure of our muscles and our skin. And so if you get skin involvement, we call it dermatomyositis, which sounds really long, but essentially what we're saying is that it's affecting the dermis, the skin, and also the muscles, the myositis part. And the classic story is that patients with this condition will get a combination of muscle inflammation and pain, so aches in the muscles, and it's a particular kind of pain. It tends to affect your big muscles, so your shoulders and your thighs, and it tends to cause more pain in the mornings than at the end of the day. It tends to loosen up as you're walking, kind of like how rheumatoid arthritis will affect the joints. That same kind of pattern of morning pain and stiffness can happen in the muscles in myositis. We can actually measure the amount of inflammation in the lungs by using an enzyme called a creatine kinase, or CK. This is an enzyme that's in our muscles. And so when there's inflammation in our muscles, they spill out CK into the blood. And so you can do this simple blood test to see the level of CK. As with a lot of our autoimmune diseases, they don't just fix on one compartment. So whereas this is often skin and muscles, you can also get involvements in the joints that look very much like rheumatoid arthritis or other inflammatory joint diseases. In the skin, there are lots of different forms that have been reported. So one of the forms and one of the things we look for all the time in our clinic is something called Gottron's papules, where you get these bumpy red lesions on the knuckles of your hand. We also will see people who get something called mechanic's hands. And this is where your skin gets really rough and it cracks, but you're not actually, like, you look like someone who, you know, spends all day working with a jackhammer, and yet you're not actually a mechanic. You're, you know, a regular person who is trying really hard to make your skin look soft, and yet it's cracking and looks worn down a lot. You can get this interesting rash called a V-neck sign rash, where it almost looks like you were out in the sun wearing a V-neck and got a burn, even though you may not have been out in the sun at all. And similarly, you can get something called a shawl sign, where it over the back of the neck, it looks like you're wearing a shawl of your own skin, where it gets red where a shawl might lay. And finally, you can get, well, not finally, but one of the other classic ones is this thing called a heliotropic rash. And this is where your eyelids can turn violaceous or kind of red or purple. And these are sort of 5 of the most common skin findings, but there's actually quite a few other less common skin findings that are reported in the dermatomyositis form of this disease. The problem that we face is that it's a really challenging diagnosis to make, and here's why. Because even though these changes that I'm showing you from these pictures are really obvious, the challenge is that the skin findings can actually be really subtle. So whereas this picture of a hand on the top left shows these obvious, like, kind of red and really angry looking bumps, sometimes all you might see is just a couple of knuckles that have a little bit of a reddish hue on them. And, the truth is, when people come to my clinic, they're sometimes waiting a little bit longer than I'd like, and they might sit there wringing their hands while they're waiting for the doctor to come in. And, it's really subtle whether or not they've got a little bit of Gottron's sign or Gottron's papules, or if that's just, the way their own skin goes. Similarly for mechanics hands, this one's pretty obvious, but you can see this person just looks like they have a little bit of cracking in the skin that many of us might think we have. And so our job is sort of to figure out, is that a real finding or is it not real? On top of that, even though we're talking about myositis, which means inflammation in the muscles, some patients may not actually get muscle disease, which sounds crazy, but that's the way the disease is designed. You can get this thing called clinically amyopathic dermatomyositis. And those sound like a lot of long words, but basically what they're meaning is the amyopathic means the muscles aren't involved in this disease that's supposed to cause inflammation in the muscles. That's obviously really difficult because how do you make a diagnosis of a muscle inflammatory disease when they don't have muscle involvement? And the way you do is you find these other features, the hand findings or other things that we'll talk about today. I'm going to refer to this amyopathic myositis, people who have myositis but no muscle involvement. We call that CADM, which is a short form for this phrase that I've just written there. We call it CADM for short, but that's a whole group of patients who have muscle inflammation without muscle inflammation, right? Leave it to medicine to kind of come up with the crazy things. On top of that, the current diagnostic criteria for these conditions don't include lung disease at all. And yet a whole bunch of them get lung disease, and we'll talk about that. And so, if you come to me and I see a little bit of skin changes and lung disease, and I think you've got this condition, I can never make the diagnosis myself because it has to be a rheumatologist who makes the diagnosis, because the lungs are not one of the official criteria, even though everyone in the world knows that this disease can cause lung involvement. In fact, lung involvement is the main cause of death in people who have this disease. So it's serious, and yet for reasons that are not entirely clear, the wisdom of others, ILD is not even in the diagnostic criteria for the disease. So that's why your rheumatologist is a key ally, right? We really need them to help us to make a confident diagnosis. We raise the suspicion, we send to the rheumatologist, and they sort of say, yeah, that's a real skin rash, versus no, that's just someone who, punched a wall and got red knuckles. One of the ways, though, in our clinic that we can try and assess this is to look for these autoantibodies. And so what is an autoantibody? An autoantibody is an antibody in your blood that is, instead of normally our antibody should be targeted at infections or other things that are trying to attack us. Autoantibodies are kind of like an autobiography where you write about yourself. An autoantibody is an antibody that your body makes that's targeting part of yourself. And we can screen for these autoantibodies to help make a diagnosis, because there are very specific and less specific antibodies that can come with this disease. We break these antibodies into two different categories. There's the myositis-associated antibodies, where, we kind of see these antibodies in our patients, but we might also see these antibodies in patients who don't have the disease, and we might see these antibodies in people with other diseases. Those are called MAAs, myositis-associated antibodies. And then we have this other category of myositis-specific antibodies, or MSAs. The myositis-specific antibodies, we think that if you've got those antibodies, we have a high suspicion you have the disease because they're very specific for this disease. Not everybody who has those antibodies will have the disease, but they're highly specific for this particular group of conditions. And so, as I said, as the name implies, these myositis-specific antibodies, the medical term is that we think that those may be pathogenic. Pathogenic means that we think that that may actually be the thing that's causing the problem. and they're quite specific for this condition. And we're discovering that these MSAs, these myositis-specific antibodies, are really, terrible for our patients, but fascinating from a medical point of view. Because what's happening is these are antibodies directed at something called the synthetase complex. I apologize for all the big words, but this is just sort of the realm we're in ILD, right? So what is the synthetase complex? And it sounds fancy, but when I explain what it is, it'll be clear. The synthetase complex is the machinery in the cell that makes all of our proteins. So it synthesizes all of the proteins. So it synthesizes your hair, synthesizes your skin, your muscles, whatever's making our body, the stuff that makes us up, that's all made up of proteins. And the part of your body that's making, the part of each cell that's making those proteins, we call it the synthetase complex because it's this complex thing that comes together to make proteins. These myositis-specific antibodies seem to be antibodies that are targeting that synthetase complex. And there's a whole bunch of different antibodies, and more are being discovered every year that we are realizing are associated with this condition. And now you can see why this condition can cause effects all over the body, because every part of your body is synthesizing proteins and doing stuff. And so these antibodies will hit different parts in different parts of your body. And the different antibodies will actually attack different ways in different organs. And so one antibody might cause more skin disease, another antibody might cause more lung disease, and they are associated with different prognosis as well. So that's sort of what we're talking about when we talk about myositis. So myositis being inflammation in the skin, in the muscles, maybe the skin, often the lungs, caused by, we think, these autoantibodies targeted at the synthetase complex making proteins. As you can imagine, this is a really diverse group of disorders then, because all these different antibodies have different manifestations. And the rates of lung involvement are really wildly variable depending on what case series you read. Some publications will say that 20% of people with myositis will get lung disease. Others will say that up to 90% or 86% of people with myositis get lung disease. And a lot of that has to do with different disease definitions, different antibodies, different duration of follow-up, like how long do you follow people to see if they develop muscle disease 1 year and then 3 years later they get lung disease. And there's also a lot of selection biases and publication biases. Like if you've got 86% of your patients have lung disease, you might publish that because you think people will think that's interesting. Whereas if it's 20%, maybe you don't publish that as much, right? So we don't really know where the truth lies. And so on top of not knowing how often the disease affects the lungs, because of all these differences, the different definitions, the different antibodies, the question is, can you really compare all these different studies and papers? Or are we comparing apples to oranges, right? Are different papers actually describing different subsets of this condition that are truly different? We know that the lung involvement is not directly related to the muscle and skin disease. So you can get patients who have this CADM where you get lung disease but no muscle disease. But even if you get both lung and muscle disease, your lungs might be getting worse while your muscles get better and vice versa. So it really involves a very careful relationship, as I say, with your rheumatologist to track both the lungs and the muscles. And in with that, the lung disease can be really variable. Some people can have slowly progressive disease that gets much better with treatments with a low mortality, and others can get this really rapidly progressive disease that has, that people can die within weeks or months of getting a diagnosis. So it can be really variable. So that we've talked about the epidemiology of it in the sense that what's in the literature. But now the question is, well, how often is this happening? Like, why am I talking about this thing that you may or may not have actually heard of before, right? And so we looked at our registry. Many of you may be familiar with something called the CARE-PF registry, the Canadian Registry for Pulmonary Fibrosis. We're one center, and Back in 2019, we only had about 400 patients in the registry. Now I think we're well over 1,000. But when we looked at our data, what we found, which was pretty surprising, was that everybody talks about IPF or idiopathic pulmonary fibrosis. But in our clinic, it's actually autoimmune lung disease or connective tissue disease associated lung disease that makes up even more patients than IPF. And in that autoimmune lung disease patient, myositis is the most common disease that causes autoimmune lung disease in our clinic. So if you take one specific diagnosis, IPF is still the most common. But if you compare it to the group of myositis, scleroderma, rheumatoid arthritis, that whole group of autoimmune diseases, they're more common than IPF in our clinic. And myositis is actually the most common. Now that's weird, because you've not heard about this. So why is Toronto seeing so much myositis? So here's why. And I had always, I have to be honest, even when I first graduated, I always suspected that this disease was more common than we thought. And so one of the things that I did when I came to our program here in Toronto is I brought myositis antibody testing to the Toronto General Hospital. And once we did that, we did a screening system where every patient who got referred to our clinic would get myositis antibody testing. And in 2019, Dr. Fiedler, who's one of our previous fellows and now one of our members and a great doctor, did his, during his master's, he analyzed the data from our experience. And we found 165 patients who had been referred to us with no clear diagnosis, like the doctor who sent them to us couldn't figure out what was wrong with them. They didn't have an autoimmune disease. And what we did is we had all of them get a panel of these myositis-associated and myositis-specific antibodies, which, by the way, are not paid for by our provincial payers. And there's nowhere in the country where this testing was paid for by provincial payers. You can pay out of pocket, but it usually costs about $200, which is a lot, in addition to all the other tests that you may need to do. And so we were paying for this as part of our protocol, and we checked all these different antibodies. And what we found was 26.7% of people actually had a positive antibody. These are people who referred to us with ILD and the diagnosis wasn't clear. A quarter of them had myositis antibodies. And when we looked at these myositis-specific antibodies, that was still about 10% of them. And so this is an interesting graph that Lee made during his paper, where if you look, it's a bit messy, but I'll just explain the basics of it. This is what people will look like at the time of referral, and here's what they looked like after we had seen them. And what you're seeing is that at the time of referral, some of these patients had IPF, some of them had a mishmash of other weird things, but a whole bunch of them had orange, which is ILD-NYD, which means not yet determined. So by definition, this is a whole group of patients where we didn't really know what they had. And at the end of that time, you see that two things happen. Once you get seen in our clinic and we did these antibodies and all that, a whole bunch of patients who were called ILD-NYD, we were able to give them a diagnosis of IPF. That's the blue. So not surprisingly, a lot of the people where the referring doctor said, I'm not sure what this is, we saw them and said, no, this is like more typical IPF, the kind of ILD that you'd see everywhere. But then look at this yellow bit. Remember, none of these patients had autoimmune connective tissue disease or rheumatism before. And then there's this whole section of patients where we actually changed their diagnosis thanks to our myositis testing. 8.5%. So not everybody who had positive antibodies ended up having myositis, but 8.5% actually had a change in diagnosis from this testing. So the question now is, should we be testing everybody for myositis antibodies? And the answer is, I think it's important to be clear that the patients who get referred to the Toronto General Hospital ILD clinic are not the same as every patient who's got ILD in Canada, right? Community respirologists are often really comfortable making a diagnosis and starting appropriate treatment for people who have a lot of lung diseases. And there's something unique about the patients who get sent to us where the community respirologist is like, I don't know what this is, right? So I would argue in that group, we should probably be doing antibody testing. But should every single patient with ILD get myositis antibody testing? I actually think the answer is a definite no, right? If we have no suspicion and we think we're pretty confident that we know what this is, we shouldn't waste both your money or taxpayer dollars. But taxpayers are never going to pay for this because it's too uncommon and hard to advocate for, because we're talking about a handful of cases. But we shouldn't make our patients pay $250 for a test that most of the time is not going to change anything. So I'm now going to shift gears. I've talked for about a half an hour. We've talked about what myositis is. We've talked about what kind of causes it, this antibodies that affect the muscles and the joints and the skin and the lungs. We've talked about how common it is and why we think we see a lot more of it at the Toronto clinic than elsewhere. And I do think that there's a lot of myositis hiding out there that people don't know about because they don't check for it. In the next bit, I'm going to talk about how we treat this disease. So, as with all interstitial disease, when our patients are coughing and short of breath, we have to be cautious because there are so many different reasons why our patients can have cough and shortness of breath, right? Many of our patients are on these immune suppressing medicines, so we have to worry about infection. They might have something called chronic aspiration. This is where you have weakness in the muscles of swallowing and the food actually goes down the wrong way. So they can be chronically having their dinner go into their lungs. That'll make you cough and feel short of breath. Their muscles may be involved, so they may be short of breath only because their muscles are so weak, it's hard for them to breathe. Or even some of our medicines like prednisone can actually make the muscles weak. So we may be treating the inflammation in the muscles, but in the end, their muscles actually get weaker because of the side effects of our drugs. And then they have things like pulmonary hypertension or high blood pressure in the lungs, which I won't go into too much detail, but that's a rare complication from either autoimmune diseases on their own or just interstitial lung disease can cause pulmonary hypertension. And these are different categories of high blood pressure in the lungs. So we have to have a broad, we call it a differential diagnosis. We have to think of what all the different causes could be. And when we're treating these patients, we go back to our general principles. And I actually kind of hate my own slide here because this is supposed to be a picture of like what your mom would do if she was taking care of you, right? Your mom knows how to take care of you. Although the reason I hate that is like dads are also really good at taking care of people, right? It's not just moms. But we go back to our basics of what would our parents do for us to take care of us, right? They would do all the things that make sense, right? They would look for other conditions like heart disease or asthma or emphysema or acid reflux, like treat other things that might give you symptoms that make you cough or short of breath. They would tell us to go exercise, right? Because we know that all of us are probably not as fit as we should be, although I'm guessing that there's some really fit people on this line, but I am not as fit as I should be, I'll admit. And so if our patients are short of breath, we should consider sending them to pulmonary rehab where they can learn to exercise and get fit and active. Vaccines are essential, and I'm going to guess always when I give this talk in the last 4 years, there's been questions about vaccines, but in general, I would say that we should be getting influenza vaccines for our patients every year, pneumonia vaccines if you're eligible and not over and over again, but they should get them. COVID vaccines, how often, I'm not sure. Some rate of COVID vaccination, maybe every 6 months or so. And now there's this new RSV vaccine that is coming to Canada. So, you know, what we do with vaccines is not entirely clear, except to say that I'm a big vaxxer. So if you can stick it to me, I'll take it. And for most of my patients, that's the philosophy I live by. Once we get beyond sort of the overall things of taking care of the whole body, then we start talking about how do we treat this inflammation in the muscles. And this is where we talk about immunomodulatory therapy. So that means to modulate the immune system, to adjust it so that it's not too strong or too weak. And so I'm going to use a case to kind of highlight all of the treatments that we're going to give over the rest of the talk. This is a 38-year-old previously healthy woman of African descent who presented to the emergency room with 2 weeks of shortness of breath. She had pretty mild muscle weakness, but she did have mechanics hands. Like she had a little bit of weakness and a little bit of mechanics hands. And when she came to the emergency room, her oxygen saturations were 78%. Those of you who are familiar with oxygen levels know that that's really low. Those who aren't, that's really low. She was in moderate respiratory distress, and she actually was intubated, which means that they put that tube in and put her on a ventilator in the ICU. They did blood work, and they showed these antibodies. One of them is an anti-Rho, which is one of these myositis-associated antibodies, but the other one is called an anti-Jo1, which is a myositis-specific antibody. This is what her scan looked like. I know you may not be an expert at looking at scans, but you'll see this scan a few times and it'll become clear what's abnormal here. But what we see is the report described that she had diffuse, bilateral, which means both sides, ground glass and consolidation, which means that her lungs, which should all be this nice gray color, like where I'm pointing with my mouse right now on the top left, it should all be nice and gray like that. But instead, what you see is all this patchy, cloudy stuff in both sides. That's the abnormality. And I'm sort of highlighting how you can see normal lung is highlighted in green. The abnormal lung is highlighted in red, right? That's the ground glass and consolidation. So she had quite a few poor prognostic factors, this poor young woman. By the way, I'm going to, spoiler alert, this woman is followed in my clinic almost 10 years later and is doing great. But she had a few risk factors, and the main risk factors for having a bad outcome are being of older age, being of African descent, this CADM where you've got myositis, but the muscles aren't involved, that's actually a worse prognosis. Getting really sick when you first come in, so if you end up in the ICU, and worse lung function, which is sort of part and parcel of the same. And then we talked about these different antibodies, and I'm not going to go too in depth in that panel of antibodies that I showed you Dr. Fiddler checked for, but there's some, particularly this MDA5, which is a very, a sinister antibody that causes the worst disease. Jo1, which is what our patient had, is actually the best prognosis. And then on your scans, the radiographic picture, if you have more scarring, that's obviously going to do worse than someone who has more inflammation, because we can't get rid of scar, but anti-inflammatories can deal with inflammation. So this patient had several bad outcome measures, right? So we were really worried about her. So what were we going to do? So we've got a bunch of drugs in our arsenal, and I'm going to briefly go through these drugs so that those of you who might be seeing doctors and talking about them will be aware of what the evidence is for some of them and be able to potentially advocate for yourself. And then we're going to work through, those of you who saw me give the scleroderma talk a few years ago, there's different slides here, but it's a similar algorithm. Basically, I'm going to walk you through how I treat my patients and why. And I appreciate that this looks more complex than being president, but once we get to the end, it'll hopefully make sense what we're doing and why. So first we have to talk about prednisone. Prednisone is like, I don't know if I'm dating myself, but it's kind of like J.R. Ewing. It's like the person you love to hate. You need it around because it wouldn't be the same without it, but you hate it so much, right? I don't know if people watched Dallas back in the days, but prednisone is an essential part of our arsenal, but it's a nasty drug with tons of side effects. The other problem with prednisone is that even though it works, when we stop the drug, when we use monotherapy, which is prednisone alone, as we go down on the dose because of the side effects, the disease can come back. In general, we use pretty big doses of prednisone. So we'll use up to 1 milligram per kilogram for the first month. That's a lot. So people who might be on prednisone and know, like, low doses are sort of 5 to 10, medium doses are sort of 30 to 40. If you're a person my size, like, you'd be getting 70 to 75 milligrams. So that's a big dose of prednisone, and we go slow. If it's really bad, we'll go as high as giving 1,000 milligrams. We use a different drug called solumedrol, but we use 1,000 milligrams when we're really worried about our patients. But you can only do that for a few days because the side effects are too bad, and then you go down. The problem is that not everyone will get better with prednisone. And as I mentioned, this CADM which was where the muscles aren't involved. So you get a low CK. Remember, that's the blood test that looks for muscle involvement. That's a risk factor for people who don't get better with prednisone. And so this graph here on the right just showed people who responded to prednisone and people who didn't respond to prednisone in this small paper, but it was illustrative. What this paper showed is that the people who had a higher CK showing more muscle involvement, they were more likely to be a responder, whereas the non-responders were more likely to have had a low CK at the beginning. So if your muscles aren't involved, that's a bad prognostic factor. So what do we use in addition to prednisone? So we have this drug called cyclophosphamide. Cyclophosphamide, we don't have any good data in myositis, but we have a really good paper called the scleroderma lung study, where we gave cyclophosphamide or placebo to people with scleroderma, which is a very similar condition. And what you saw was at the end of a year, they had some improvements. So the solid lines are the people who ended up on placebo. You can see their lung function kind of stayed the same throughout the whole treatment. The cyclophosphamide patients are in the circle, the open circles. And you can see after about a year of treatment, their lungs got a little bit better. Interestingly, we stopped the treatment here. And when we looked at their lungs, they actually got even better for the next 6 months, even when the drug was stopped. But cyclophosphamide has long-lasting effects. But if you didn't continue on the drug, even though you got better for the first 6 months after you stopped it, at the end of 2 years, so a year off the drug, all those benefits were lost. So it sort of tells us that we need to treat these patients long-term. You're not going on this drug for a few months. You're going on this drug long-term. In myositis-ILD, there are no randomized trials, so we extrapolate from the scleroderma lung studies 1 and 2, and I'll talk about the scleroderma lung study 2 in a moment. There are some non-randomized trials that showed, if you look at vital capacity, which is a measure of lung function, that improved in this meta-analysis. They had 60 patients and about 58% of them got better. Diffusion, which is your ability to exchange oxygen and carbon dioxide, that got better in about 64% of these patients, and the CT improved in about 2/3. So this is not great data, but it sort of suggests that when we looked at a pool of non-randomized studies, it seemed to work. The problem with cyclophosphamide is it's not very well tolerated. It can affect your blood counts. It causes thinning of your hair. It can cause bladder damage. It can actually cause menopause, which is obviously a significant thing, particularly, in this case that I just showed you of a young woman who's, coming in, ending up in the ICU. And cyclophosphamide is associated with getting more cancers late in life. It's not a huge increase, but it's there. So we really reserve cyclophosphamide for our sickest patients. The next drug I want to talk about is something called IVIG, or intravenous immunoglobulin. This is actually a really new and exciting area, and this is part of why people want to hear about myositis. So what is IVIG? So intravenous immunoglobulin is pooled antibodies from people who have donated blood. So people think when they donate blood, they're just donating blood for someone who had a surgery or who got in a car accident. But when you donate blood, and please donate blood, when you donate blood, one of the things they do to that blood is they take out all of the antibodies in that blood, and they pool the antibodies from a whole bunch of different donors and create this thing called IVIG. It is a pooled sample of antibodies from a whole bunch of donors. And we can give that to people. So why would we give people extra antibodies if we think that the disease is caused by antibodies? And that's a good question. But there's a couple theories why IVIG might work. And the two theories are, first of all, we think that regular people have what we call these regulatory antibodies. These are antibodies that are kind of like turning down the volume on the amplifier, right? Just sort of, they keep your immune system in check. And so the feeling is that giving people other pools of antibodies from other people, there might be someone like the teacher in the classroom that's sort of saying, hey, you, calm down, sit down, relax. So you might get some of these regulatory antibodies that kind of calm everything down. There also we're giving lots of antibodies. And so the idea is maybe what we actually do is we just drown out the signal from the bad antibodies by giving so much good antibodies. So that's the theory. IVIG was studied in a really famous paper that came out last year in the New England Journal of Medicine. And for those who aren't as familiar with medical literature, that's like the biggest medical journal in the world. So you know it's going to be an impactful paper when it gets published in the New England Journal. This was a randomized trial of giving IVIG to 95 patients with very difficult to treat dermatomyositis. So these are people who were on stable doses of prednisone and up to 2 other drugs. So 3 drugs in total to control your dermatomyositis. You weren't allowed cyclophosphamide in the trial, and that's just because that's usually given to people who are just like so sick in the ICU, you can't really enroll them in studies. This wasn't really an ILD study. Only 5% of the patients had ILD, but they looked at their muscles and they measured this thing called the total improvement score, which is just some like composite of like how much did you improve. And what they saw was a dramatic increase in the number of people who improved, who met this total improvement score of 20. In fact, it was 79% of people in the study. Remember, these are people who had failed on all these other treatments. 79% of them improved once they got IVIG, whereas only 40% of the people in the placebo arm got better. And what was wonderful about IVIG is it happened fast. The average response rate was at about 35 days, whereas in the people who didn't get the drug, even if they got better, it happened more slowly, like it happened over the course of 100 or more days. So IVIG is really exciting, but I can't tell you too much about the ILD because they didn't really look at ILD in this study. And so far, the data for ILD and IVIG is anecdotal. There's these small case series. But I can tell you, in my experience, this drug works, and I have used it a lot in my myositis patients for years because we've always suspected it worked. The problem is it's really hard to get because it's a blood product. So you can't just like write a prescription for, a blood transfusion to be given every month. And so before recently, we could give it when you were in hospital and really sick, but it was very hard to give long-term. But I am convinced that IVIG is going to become a major player in the myositis world now. And so hopefully we'll get a lot more data and experience with long-term IVIG in the ILD group because now we can get it. But in my experience, when we give it short-term for really sick patients, it really does work. So let's go back to my treatment algorithm that I talked about. I've got a confirmed diagnosis of myositis lung disease. If you've got high-risk features, like if you've got really severe disease, you're in the ICU, you've had rapidly progressive disease, if you've got one of these bad antibodies like that MDA5, or if you didn't get better with prednisone, in those patients, I give prednisone with cyclophosphamide, and if I can get it, I add IVIG. And these days, I can get it thanks to that ProDerm study that we talked about. So let's go back to our case and look at what actually happened to her. So this was this 38-year-old woman who had severe ILD. As I said, she had this muscle weakness and a slightly high muscle enzyme. She had positive myositis antibodies. So we made the diagnosis of inflammatory myositis. We gave her really aggressive therapy. She's 38 and in the intensive care unit. We did everything. We gave her solumedrol, 1,000 milligrams of prednisone, and then stepped down to prednisone like 50 milligrams. We gave her IVIG. We gave her cyclophosphamide. Remember, this is like 10 years ago. So I already really was convinced that this was going to be somewhere in their treatment algorithm. And she got way better. So even though you're not an expert at looking at scans, this is what her scan looked like 6 months later. And I want you to remember all that cloudy stuff that I showed you was abnormal and see how much the lungs have turned to a nice gray now. There's much less inflammation in those lungs. So the question is, what do I do now? She's doing better at 6 months. So the problem is you can't stay on cyclophosphamide forever because of the risk of cancer and menopause and all that stuff. So then we switched to a drug called Mofphenolate. You may remember mycophenolate. I had talked about it a couple years ago when I talked about scleroderma, and it's a lot of the same data. This is a scleroderma lung study 2 that compared that cyclophosphamide drug I talked about earlier to mycophenolate. And basically what they showed is that both groups improved. You can see the lung function in the cyclophosphamide group is in red, the mycophenolate arm is in blue, and you can see lung function got better in both groups. There was no difference between the groups. And although there's some problems with this study, it's really exciting because mycophenolate has way, way less side effects than cyclophosphamide. And you can stay on mycophenolate for many years. So we talked about how if you stop the drug, cyclophosphamide, people get worse. So you need to stay on treatment long-term. If you can't stay on cyclophosphamide long-term, we're very excited to have mycophenolate that we can use. That was a scleroderma study. This is a myositis group, not particularly myositis. This is sort of like a whole mishmash of rheumatologic patients. So rheumatoid arthritis, scleroderma, myositis, and about a quarter of these patients had myositis. This is not a randomized trial, it's just a retrospective. So it was looking at 125 patients that we treated and how did they do when we look back. And what you can see is that before mycophenolate, their lung function was sort of slowly going down by 2% a year, then 1.5% a year, then 1%. Like slowly their lung function was getting worse. Then we started mycophenolate and you can see their lung function improved by 4%, 5% in the first year, 6% in the second year, 7% in the third year. So even though we don't have perfect data for myositis, the combination of the effectiveness in scleroderma and this paper and a few others make us think that this is a really viable option. Azathioprine is another drug you may have heard of. It's kind of like a version of mycophenolate. Azathioprine is cheaper than mycophenolate, but has a little bit more side effects, more nausea and stomach upset. But it's the old version. It's the version of mycophenolate that they were using back when I was in my training. And this one kind of compared azathioprine to mycophenolate, and they both kind of worked. So you can see in whether you got azathioprine or mycophenolate, lung function seemed to go up the same in both groups. But even though azathioprine is cheap, it has more side effects. So we generally use mycophenolate, but mycophenolate still costs about $150 to $200 a month. Azathioprine costs $2 to $5 a month. So when people who don't have private insurance and can't get coverage, particularly people who are, in their 30s, 40s, and 50s, azathioprine is a really nice, cheap alternative, although it can have a bit more side effects. So going back to my treatment algorithm, we give patients these heavy-duty drugs when we're really worried about them, but once we've stabilized them, we're going to step them down to either mycophenolate or azathioprine and kind of wean down the prednisone. On the other hand, if you're a low-risk patient, you don't have a lot of risk. You're younger age, you're not as sick when you first present, your scans look more inflammatory than scarring. We may just monitor you and only start mycophenolate or azathioprine if you're getting worse. So we wouldn't use these heavy-duty drugs like IVIG and cyclo in those patients. We just use mycophenolate. So looking at our case, our patient had done well. We stepped her down to mycophenolate. Then we slowly weaned down the prednisone. We got her to just 5 milligrams a day, so 1 pill a day. So she was doing really well. The problem is she was sort of slowly getting worse over time. She got Gautrins. That was those like pink rash on the knuckles that came back. And she got a little bit more short of breath. So we did a new CAT scan. Again, I appreciate you're not experts at looking at scans, but I'm going to show you. This is what her scan looked like when she was doing well. And then I just want to show you in that red circle, you can see how some of that cloudiness is starting to come back. Can you see how it's looking white and cloudy again in some of those areas? So what would you do next? The next drug I want to talk about is rituximab. So rituximab is a really interesting drug that is very exciting. This is another one where it's a big change from a few years ago. Rituximab is a drug that goes into your body and attacks the B cells. So what are B cells? B cells are the cells in your body that make antibodies. So our immune system is kind of broken down into a few parts. One part of your immune system is the part you're born with that can attack anything. And then you've got what we call the acquired immune system, the part that you grow, that you develop as you grow older, that gets exposed to infections and then learns how to fight those infections. That's the acquired immune system. And the acquired immune system breaks into two big parts. There's the T cells, which are like the attacker cells, and the B cells are the ones that make antibodies. So rituximab basically wipes out the part of your body that makes antibodies. So remember, if we have these antibodies that cause the disease, if you wipe out your ability to make antibodies, that might reduce these anti-synthetase antibodies that are attacking yourself and make you better. And rituximab is used in a lot of diseases where the B cells are abnormal. Initially, we were using it in B cell lymphomas or B cell cancers, but we found that lots of diseases like rheumatoid arthritis will get better with rituximab. There was an old study in 2015 that was 34 patients with myositis who got rituximab for a year and showed that a whole bunch of them got better. Overall, the median or average lung function went up by 24%. The CT improved in 22 out of 23 patients. But this isn't a randomized trial. This is just one center's experience. So in January, there was a very landmark paper called the Recital trial that came out. And the Recital trial was a phase 2 study that compared rituximab to cyclophosphamide. You see why I have to tell you about one drug to understand the others, because they're all compared to each other. So this drug gave our old treatments, the aggressive as cyclophosphamide, and compared it to rituximab. They had 100 patients. About half of them, 45% of them had myositis, but a lot had scleroderma and other autoimmune diseases. And in the end, both groups improved. It is remarkable how similar this is to the scleroderma lung study too. Both of them are actually officially negative trials because we were hoping that the treatments would be better than cyclophosphamide, but they weren't. On the other hand, both groups showed that cyclophosphamide works, mycophenolate works, and rituximab works. Even more recently, just in May, there was a study called the ILD study that compares mycophenolate plus rituximab to mycophenolate alone. You know, like you just keep on pounding, you know, we're hammers, we just keep on pounding. So give both of them together. This was 122 patients who got either mycophenolate alone or mycophenolate with rituximab. And what we actually saw is the rituximab group did better. This graph on the right is showing the number of people who did not progress. So this is called a Kaplan-Meier curve. So basically, as the numbers go down, for each time this takes a step down, that's a patient who got worse on treatment. And so you can see in the placebo arm, there were more steps down than in the rituximab group where more people didn't have a step down and they remained stable. So there's lots of different endpoints here. We can look at lung function in percentage and milliliters. But the one that I think is the most useful for us is this progression-free survival, that you're surviving without having your lung disease progress. And that was more common in the rituximab group. So you all kind of want to clap because you're very excited, like we've got our solution, right? But the problem is, don't get too excited yet, because rituximab has been a big challenge over the last 4 years. So 5 years ago, I would have said, awesome, we got it. But the challenge is that we all remember back in the days when you were getting your COVID boosters and they were talking about how your antibody levels for COVID would go down, and so you needed a booster. Well, what happens with COVID if I'm giving you a drug that is getting rid of all of your antibodies, not just the myositis antibodies? So if there's any Americans on the line, it is a pleasure to have you here. And I have to say, it is one of the pleasures that we have in Canada, that in America, they had a very different philosophy about COVID-19. There was a lot less vaccination, a lot less masking, and as a result, there was a lot more COVID. And I'm sorry for anyone who might have had to experience that personally, because we don't make light of it. It's a really serious problem, but like any bad things that happen, we have to try and learn as much as we can from that. And so this paper, published in February, looked at 23,000 patients in the US who were in this registry. And these 23,000 patients didn't just get COVID. They are people who had rheumatoid arthritis and got COVID. So that's massive, right? 23,000 patients with just rheumatoid arthritis who had COVID in this one registry over like a year and a half. When they looked at the 23,000 patients, 364 of them had gotten rituximab during that time. And what they found was, compared to all the other drugs that people got for their rheumatism, and there's a bunch of drugs we treat rheumatoid arthritis with, compared to all those drugs, patients with rituximab had higher rate of hospitalization from COVID, higher ICU admissions from COVID, and were more likely to need a mechanical ventilator or those machines to help you to breathe. What does this mean? Does this mean you can't take rituximab? No. If you need it, you should take it. But the idea is two things. First of all, we have been less excited to use rituximab than before COVID. And of course, it's really important that people who are getting rituximab should maximize their COVID-19 vaccines. You need to do, these are the patients, when we talk about people who are still worried about COVID and still trying to protect themselves, most people, even people with interstitial lung disease, most people by now have had many doses of vaccine, have had COVID, to be honest. Most of the people have had COVID. But when they did have COVID, most people with lung disease who've had many doses of vaccine actually do very well. In fact, most of my patients who come to me who are still wearing masks 24 hours a day, I say to them, like, you can do that, but this is how life is going to be forever. And the good news is that if you take off that mask and you get COVID, you might get quite sick, no guarantees. But in general, compared to before the vaccines, when we were getting calls that our patients were in hospital all the time from COVID, nowadays, the vast majority of our patients, even with fibrosis, if they're multiply vaccinated, they get COVID, they tend to get sick, but they tend to recover quite nicely. But patients on rituximab have to continue to be really cautious. I'm going to be a bit brief when I talk about another drug called tocilizumab, but I just want to mention it so that people who might be on this drug will be aware of what it is and what it does. This is a drug targeted at something called IL-6, and don't worry too much about what that is, but basically IL-6 is a chemical that helps our B cells develop. So whereas rituximab directly attacks the B cells, tocilizumab is interfering with the development of B cells as they grow up. And so again, the same idea. By reducing the B cells, maybe we get less of these antibodies. What's nice about tocilizumab is that it is actually very safe in COVID. In fact, early days of COVID, we used tocilizumab for people who ended up with COVID-19 and in the ICU. It's an effective treatment for COVID. And how that is a bit complex that I don't want to talk about, because when it's killing the B cells, why is it, not bad in COVID? And the answer is because killing the B cells is like a late effect of tocilizumab, but IL-6 itself actually has other bad things that it does when you get sick with COVID, and it helps with that. Tocilizumab was studied in something called the Focus study. This is a scleroderma trial. And basically, it showed that there was no effect on the skin, which is one of the major problems of scleroderma. But when we looked at the lung function in the tocilizumab group, that's the red line, it stayed flat, whereas the people in the placebo arm got worse. So tocilizumab is quite exciting. In the US, actually, tocilizumab has been approved to treat scleroderma ILD. But the question is, is it going to work in myositis? We don't know. Is it that hammer and nail thing where if it works on one disease, it'll work in the other? We don't know. And also, because this drug is not approved in Canada for this condition, it's approved for rheumatoid arthritis. but not scleroderma or myositis, who's going to pay for it? Private insurers won't pay for it, government won't pay for it, so it's hard to access. So going back to our treatments, we get to this point where our patient is stable on Mofphenolate and Prazone. If they're getting worse and they have a lot of inflammatory disease, I would switch to or add rituximab, maybe IVIG if I can get it, or maybe tocilizumab if I can get someone to pay for it. And that's sort of how my walk through the immunomodulatory or immunosuppressive treatments goes. In the last section about treatment, I'm going to change gears completely. So I'm going to remind you about our patient, and they've got a whole bunch of scans here, and I know you're not able to process it all, but I'm going to just highlight for you. This was our patient when she was doing well, and you can see there's a lot of gray lung, not a lot of that cloudy ground glass and consolidation, the abnormal stuff. I showed you when she had that minor flare, when things kind of got more inflammatory, and what we actually did for her is we increased her prednisone a little bit. We did not go on rituximab because we were worried about the immunosuppressive effects in COVID. With a bit more prednisone, she actually got better. You can see that in that green circle on the far right, you actually see that that cloudiness got better. But now what you're seeing in the red circle is something that looks a little different. Now it's not white and cloudy. You're seeing all these lines and holes and changes that look to us like fibrosis. This is what scarring looks like on the lungs. So now you see how we can sometimes tell the difference, how inflammation looks white and cloudy and fluffy. Scarring looks coarse and linear, and it changes the architecture of the lungs. And that's what you're seeing in this red circle right here. So this is where we go to a whole new world, moving away from immunosuppressive treatments and going to these anti-scarring medicines or anti-fibrotics. So the theory behind this, it's a whole paradigm shift that you might treat scarring rather than inflammation. And the theory is that idiopathic pulmonary fibrosis, or IPF, is a disease that causes all of this fibrosis, these cytokines that cause fibrosis. Whereas connective tissue disease, ILD, or autoimmune lung disease is supposed to be all inflammation. But over time, that inflammation can start to lead to a bit of scarring. And once you get down that pathway, then you start to do this. You start to get more fibrocytes developing, and they're the ones that make scar tissue. They make collagen, which is like the actual scar tissue. And collagen itself actually stimulates these scar tissue, and you end up in this positive feedback loop that scar tissue will create more scar tissue. So the theory is that once you've dealt with the inflammation, maybe the scar tissue can actually even take on a life of its own, even if you've kind of, quote unquote, dealt with the disease. And so that's where a drug called nintedanib comes in. Nintedanib is a drug called the tyrosine kinase inhibitor. It has lots of targets along these fibrotic pathways, and many people in the audience who might have IPF are very familiar with this drug because it has been around in Canada to treat IPF since 2014 and has shown that it slows the rate that people get worse. People still get worse. This is people on nintedanib. You can see their lung function is going down over time, but people in the placebo arm of this trial get worse a lot faster. It's been available for years in Canada for IPF. But then in 2019, there was this really landmark paper called the INBUILD trial, and we were really fortunate that Toronto was one of the study centers for the INBUILD trial, and I was a pleasure to be part of this New England Journal paper. This was nintedanib in progressive fibrosing lung disease. Basically, this is nintedanib versus placebo in 660 patients, so a big study. And the key inclusion was that you couldn't have IPF. You had to have fibrotic ILD, so scarring lung disease that wasn't IPF, that had been getting worse over 2 years. And about a quarter of these patients had autoimmune lung disease. And what they showed was, if you look at the lung function drop over time, people in nintedanib, their lung function did get worse. They dropped by about 80 mils, but people on placebo, their lung function went down by about 187 mils. In fact, these results are very, very similar to that major IPF study that I showed you called the Impulses trial, where we saw that the lung function in people on nintedanib with IPF went down by about 115 mils versus 223. So very similar in the sense that people not on treatment get much worse. People on treatment get worse, but much more slowly. And the difference is remarkably similar. As far as the autoimmune patients, if you look, this paper just looks at, was there one diagnosis in this disease that benefited more than the others? And the answer is no. The autoimmune patients had the same benefit as all the other patients. So myositis, scleroderma, these patients are all potentially candidates if they're having progressive scarring despite treatment of their inflammation. So this drug is now available at a pharmacy near you. In May of 2020, it was actually approved for use in Canada. And unfortunately, our patients had to wait quite a while because it was only around April 30th, 2022, when Boehringer Ingelheim, the company that makes the drug, was able to announce officially that they had secured agreements with all of the provinces to get coverage. So that took almost over 2 years. But we are now about a year and a half where we can access this drug for our patients who need it, which is really exciting. So going back to our treatment algorithm, if you have a lot of inflammatory disease and you're getting worse, I add one of these other drugs. But if you actually have progressive scarring or progressive fibrosis, that's when I would add nintedanib instead of going to more immunosuppression. On the other hand, if you're on dual therapy with, let's say, mycophenolate and nintedanib and you're getting worse, oh, sorry, it goes the other way. If you're on dual therapy with mycophenolate and rituximab and you're getting worse, I add nintedanib. And if you're on nintedanib and mycophenolate and you're getting worse, I would add something like rituximab or IVIG or ToalZab. So having said that, it's around the time that you start getting on 3 drugs to treat your disease, right? You're on mycophenolate, rituximab, nintedanib, you're still getting worse. That's when we start to think about things like lung transplant. So is this the right thing to do? I mean, who knows? The reality is that our world, the data, I've tried to make sense of the data for you, but this is many papers that all sort of point in the same direction, but it's actually not as black and white as I've sold it, because this is, hard stuff and hard decisions to make. But in general, my philosophy is that I've come up with a treatment strategy that kind of makes sense to me. Right? And I hope to you, now it makes sense why I do what I do when I do it. So I'm at about the 1 hour mark for my talk. And so I'm going to summarize here, and then I'm going to open it up for questions. To remind you, myositis-ILD is a heterogeneous disease, which means it has all different ways that it can present, that can range from really mild to rapidly progressive and awful. We might consider doing this serology testing or these antibody testing in patients who have sort of an autoimmune flavor, where for some reason you think that there's something that I can't figure out what's going on here, and I know that there's something more than just sort of run-of-the-mill IPF. Immunosuppression is the cornerstone of our treatments. Prednisone is effective, but relapses are common. Cyclophosphamide and IVIG can be added for our really sick patients. Mycophenolate and azathioprine can be used either for mild disease or step-down treatment. Rituximab has a role for sure, but the drug has to be, used cautiously during the COVID-19 pandemic. And IVIG, I am really excited about. I think it probably does have a role in long-term therapy, but it's only become available to use long-term just recently. And so it's going to take us a few more years to know if it's really working. Nintedanib is emerging as a treatment option for all people with scarring diseases that are getting worse over time. Cost is still a challenge because the drug is very expensive, but it is covered by all provincial health plans. And with nintedanib, it's important to remember that because this disease has very little impact on stuff outside of the lungs, it's important that we have a really close relationship between respirology and rheumatology to decide what drug is best, right? If your muscles are active, I don't want to put you on nintedanib. I want to put you on something that might control the lungs and the muscles. So it involves a lot of back and forth. And my difficult myositis patients, I actually will email and talk to my rheumatologist frequently about these patients. Like every visit, we'll send an email back and forth, like, here's what I was thinking and what I'm going to do, so that they can know what I'm thinking and I can know what they're thinking. I want to say a big thank you first to the CPFF for inviting me to speak today. It is always a pleasure. I also want to thank the ILD clinic. I don't do this alone. Our clinic has 5 doctors. Their names are here and they're all amazing. I have actually multiple papers that I have talked about today, which were really landmark papers that have changed the field. The group here is authors on many of those papers. We have a strong administrative team. We have research staff. We have a nurse practitioner. And at the moment, we have 2 fellows that are not funded by the CPFF for the first time. They have funded all of our fellows up to date, but these 2 fellows that are with us this year have come with their own funding. And so we didn't go to the CPFF this year, but a thank you to them, because our fellows are people who will become ILD experts in future years. And that is one of the best things from our point of view that the CPFF has done with some of the donations from their wonderful audience. So thank you very much for having me. Thank you to the CPFF for all you do. And I'm going to stop there and open for questions.
Well, that was a lot. That was a lot. Thank you so much. And
mind blowing, right? It's a bit too much, but
no,
it's okay. You can watch it later.
It's still, yes, it will. And yeah, I'll remind everybody of that. If you want to go back and look at it again or whatever, everything, the webinars are usually up on our website within about a week. So you can go back in a week's time if you've forgotten, God knows, some little point that you wanted to make, even to perhaps your own doctor at some point. And I guess I do have there are a few questions that came in, and I wanted to, I guess there seems to be, someone was saying there's a lot of different drugs, right? We're talking a lot of drugs associated, and some of them are scary. People know that prednisone is not something great for at high rates for a long time, and that's sort of out there everywhere. So what about side effects and drug interactions, and people might have other conditions too? Like everybody's a little bit afraid of taking so many drugs. And how do we make sure that they're managed and monitored, like as a patient or caregivers too, right? It's keeping track. Yeah.
And this is always scary for our patients, because most people always sort of say, like, I was healthy until this. And I mean, the reality is, so if you talk to any patient who's ever had any condition, they were always healthy until they had whatever condition it was.
They were sick, yeah.
Right? We're all healthy until we're not. But I hear that, like, this is a big deal, to go on drugs that you're not going to take for a week. It's not like an antibiotic, you're taking them forever, or at least long term. A couple of things I'll say. The first is that these drugs can all have side effects, but other than cyclophosphamide, in general, these drugs are all actually quite well tolerated. So patients, I have started like 90-year-olds on Mofphenolate, and they do fine. These drugs, might cause a little bit of stomach upset, or, we might check your blood work every month just to make sure it's okay. But the vast majority of these drugs, people will do fine. Nintedanib causes diarrhea. That's probably the drug that has the most side effects that people feel. Like, everybody who takes nintedanib gets diarrhea. It's just part of the drug, and we can do stuff to make it better. We can adjust dosing. We can give you other medicines. But interestingly, whereas everyone's so afraid of drugs like rituximab because it sounds so strong, whereas everybody who takes nintedanib gets diarrhea, which, by the way, we have to deal with because nintedanib is a great drug. Like, it really helps. So you just got to deal with it. But drugs like rituximab, you won't even feel it. Like, you won't know you're on it. It has almost no side effects, except for this COVID problem. So what I say is, have a frank and open discussion with your doctor. Ask them for real, what are the side effects I should be worried about? But I can tell you that in almost all these drugs that I've talked about today, the thing that should keep my patients up at night is the disease, not the side effects. These are terrible diseases. And so our goal should be, at all costs, we should do what we can to manage the disease. And if people take a drug and they get side effects, the good news is you stop the drug, side effects go away. Right. The last thing about interactions is that thankfully, very few of these drugs actually interact. They play nice with each other. So you can talk to your pharmacist, talk to your doctor, but I don't worry too much. All of my patients say, well, I've also got heart disease and I'm taking this, that, and the other thing. Should I worry? And I say, don't worry. Our drugs are working on very different parts of your body than the drugs you might take for your blood pressure, your diabetes, your heart disease. It's like a whole different world. They don't interact.
Okay. Well, that's good to know. Thank you. And again, I guess you and I, sorry, we talked about this before we got started, but somebody was mentioning too that early in the presentation, you mentioned that the myositis-associated ILD is more common than, the ILD with RA and scleroderma. But how come we haven't heard much about it? And even when you were looking at studies later that were done, it would, mention by name the RA related and the scleroderma related, but not myositis when it's more prevalent than the other two. So how do you, and there doesn't seem to be as much research on this one when it seems to be more prevalent. So is there any comment you'd like to make about that? Or
yeah, so two comments. The first thing, and I know I talked a lot about stuff, but the first thing that I want to remind you is that I don't actually think that myositis is more common than scleroderma. Okay. I think it was more common in our patients at the Toronto General Hospital. And I think that's because we look so hard for it. But I think, and remember, the patients who come to us are not the same as out in the real world, because there's something unique about you. If you get referred from Thunder Bay to Toronto, there's something, your local team felt like they needed you to come down to the big city to get that checked, right? So there's something different about our patients that don't represent all patients. We also look harder for it. But the other thing that I'll say is I think part of why I'm giving talks about myositis now, and I wasn't giving talks 10 years ago, is that these antibodies that we talk about, we can check for them much more readily now. And so even 5 years ago, you couldn't look for this. So you had a whole bunch of people who had something that you couldn't name, you didn't know what it was. And it's only in the last sort of 3 to 5 years where this antibody testing has become commercially available, but it's still not covered by OHIP. So it really, or by provincial payers, because I know there's across Canada. So you really wonder how many people are out there with ILD not yet diagnosed, and they may actually have myositis. So I think you may hear more about this in the next 10 years than you did in the last 10 years. And that's why I thought this was a great disease to talk about now, be on the cutting edge.
Yeah, okay, because now, like you said, you can test for it.
We can test for it, exactly.
Yeah, okay. And again, you sort of touched on this just in your last answer here. When you said, the cases are unique that are coming to Toronto. So someone asked, how likely, is someone to be diagnosed and treated properly if they go to like an ER in a smaller center, especially like in the case you described. So how can somebody know, if they go to the community ER, like Mary, if Mary went to, the ER in, I don't know, Red Deer,
poor Mary, not Red Deer. Don't go to the emergent Red Deer. I don't know if you've heard of it. No, I'm just kidding. People in Red Deer.
Yes. Yes.
Yeah. So I think the answer is like anything. And I think it's a complicated answer, right? It's not straightforward. Yeah. The first thing that I'll say is I'm not the only good doctor in Canada. I absolutely think that's true. And I know that, right? There are lots of fantastic doctors all over the country. And you don't have to be working at Toronto General Hospital or at Vancouver General Hospital, or, you don't have to be at a giant center to be great at what you do. And I have lots of friends and colleagues who are all over the country who do really good work, even in small, remote places like North Bay and, Thunder Bay. And like, there's great.
They're taking your courses, right, Shane? Right, they've seen your seminars for physicians on this. Yeah. Okay.
And so I think there are good doctors everywhere. Yeah. The second thing that I'll say is that I also think many doctors know what they know and what they don't know. And so I think we can also trust, if you see your local doctor and they say, I'm pretty confident that I know what this is and what to do for you. I mean, you have to decide if you trust them or not, but most of them actually do know what they know and what they don't know. And they know when a patient is not in their comfort zone. You know, this is a patient who has a disease or a diagnosis or a scan that I just don't know what to make of it. I think I need help, and they know when to ask for help. So, you know, there was a time when there was stuff going around that like every patient with pulmonary fibrosis of any kind should be seen in one of the like 5 original big centers in Canada. And that's just impossible. There is like 100,000 patients with lung fibrosis in Canada. And the 5 centers that started 10 years ago, there's no way we could see them all. We shouldn't be seeing them all. We should see the ones where something just doesn't add up. And we feel like there's something different going on than the usual. And that's when you send to us.
Okay. That's helpful too. So in Mary's case, like when you were going through the Mary's case there, and you said, I can't remember if it's at the end, she said her fibrosis is increasing, but I don't think, did we get to the point where you said you would then give her an anti-fibrotic or?
Yeah, so we actually did. I didn't because I didn't go back to her story, but
right.
We did start her on an anti-fibrotic drug. She's tolerating it very well. And the hope is that it's going to slow the progression of her disease. But I have to say, I worry about her. She's a young woman, 38 years old when she first came. That was 10 years ago, by the way. We're now 10 years out. So she's doing well. She's working full time. She's off prednisone. She gained a lot of weight on prednisone and lost it all eventually.
Those side effects.
But now I worry that she is probably going to get worse. But I'm hopeful that with nintedanib, she'll get worse more slowly than she'd get otherwise. And if she does continue to get worse and gets really bad one day, I feel really fortunate that I live in a giant lung transplant center. And at 38 years old, she might be a great candidate for that. But we all know that lung transplant is not, it's our last option, not a great option.
Yeah. So, and again, I guess we're looking at this, at Mary's case, that someone, I guess, typed in earlier about, so is her case unusual, they said, is because she's younger, but she has like, so she's not, doesn't have that risk factor, but she did have, you know, some muscle and skin, but then she ends up in ICU. So was the ICU part sort of like the determining factor to be the big, because otherwise she seemed a little more on the other stream, you know, you had those 2 streams.
And I would say that most of the patients, probably the vast majority of patients that we see are on sort of the right side of that algorithm where they have mild or you know, mild to moderate disease and we can control them in the outpatient setting. They don't end up in hospital. She's an unusual case, but I certainly see that, you know, we see many of those per year. And I used a particularly sick case because it gives me an opportunity to talk about what we do when you are really sick. But thankfully, the vast majority of our patients are on that right algorithm where we can use Mofphenolate and maybe add nintedanib, and they can do quite well.
Yeah, much better. And also at the end, you mentioned again, and you sort of reiterated about how important that communication is between the rheumatologist and the ILD specialist. Now, would patients have to be encouraging that conversation, or like did they have to be the conduit between the two? Like, okay, my rheumatologist says this, you're telling me that, or, you know, can patients, you know, advocate to say, okay, you guys talk to each other? Like, is it common? Like, is it happening that they are speaking to each other?
Yeah, I think that they probably are speaking to each other out in the real world, but not as much as they could or we'd like them to. I think that your question about should patients advocate for themselves, the answer is always going to be yes. And that's what the CPFF is all about, right? Patient advocacy is a key thing. And it's a fine balance for a patient to figure out, how do I go from being an advocate to an irritant to my doctors, because you don't want to push too hard. But on the other hand, you are your strongest advocate. So there is absolutely nothing wrong with every visit to your lung doctor and your rheumatologist saying, did you get the last letter from them, because I might email with the rheumatologist, but in the real world, again, people probably aren't emailing every visit. So did you get their last letter? And if you didn't get their letter, let me know, because that way the next time I go back to that doctor, I'm going to say, can you make absolutely sure you copy not just my family doctor, but also my rheumatologist on the letters?
That's a good idea. Yeah.
There's also something, more and more, there's these patient portals, right? Like our UHN has this patient portal where I write a letter that goes to your family doctor, and you can see it on your iPhone now within a day, or
send it to whoever.
Right. So what you might do is you might, to be your own advocate, you might print that last letter and come with like a paper copy of that letter when you see the rheumatologist. So when you say, did you get that last letter from Dr. Shapera? And she says no, you can say, oh, well, here it is.
Here it is. That's very good. That's a good tip. And yeah, and I remember when Dr. Pope was on earlier, did an earlier webinar here.
She's awesome, by the way. I'm such a fan.
Yeah.
I get a little like starry-eyed whenever I see that.
But because she did also say, that she's doing some things that not every rheumatologist would do. Like every visit, she's always listening to her patient's lungs just to see if that's coming up. That might not be standard practice for every rheumatologist. So it's good to know that the two specialists are in touch at least, or
absolutely.
Don't
we wish everyone could be Janet, but it's not possible.
Yeah,
she's awesome.
No.
But I also I will say that just like we talked about, do you have to see Dr. Pope to get the best care? And the answer is that she's awesome. And like some of the other experts that you guys have speaking, she's involved in clinical trials and does all this really cool stuff. But there are a lot of really excellent rheumatologists who might not listen to your lungs every time, but that's okay. You tell them if you feel like your lungs are worse and it needs a listen.
Yeah,
don't bug them every time, but if you're coughing and feeling more short of breath, and say, do you want to listen to my lungs too?
Yeah, exactly. It's not, depending, sometimes there's a list. That's usually more for the family doctor. You only get 3 things to talk about, or only get 2 things for a visit, or anyway, I thank you so much. I'm at the end of my questions. If there's anything else you wanted to jump in with.
I think we're right on time. Our goal was to be sort of wrapping up at around 3 o'clock, and I am thrilled about all the questions. And I just want to thank you guys for having me, and thank you for your advocacy. And thanks to everyone out there who wants to learn about this disease and help us spread the word. So a real treat. And I can't wait to come back and talk to you guys about something new next year.
Oh, you'll be invited. All right. Thank you, everybody. I'm going to sign off now.
Thanks, everyone.
Thank you.